Well, if somebody really is allergic to penicillin, or they really did have an allergic reaction to the cephalosporins, and you need to kill something in the upper respiratory tract, you're probably going to give a macrolide. Here's what I want you to know. This prefix macro means big. Chemically, the macrolides are very big. What does that mean for you as a prescriber? Anytime a drug is chemically very big, like the psych drugs or the macrolides, you know what that means? They interact with a lot of other medications. And that's a common characteristic of the macrolide antibiotics. They're dirty drugs. Erythromycin is filthy dirty. Thank goodness we hardly prescribe that anymore. Clarithromycin is filthy dirty. It interacts with all sorts of medications. So we rarely prescribe erythromycin. But the two macrolides you see used all the time are azithromycin and clarithromycin. And according to Sanford Guide, the Bible of antibiotics, the reason you give either one of those two antibiotics ought to be to kill an atypical pathogen like a Mycoplasma chlamydophila pneumoniae, not to treat strep throat. Strep throat. Amelie, we use that all the time. I know you do. That's why Sanford Guide says stop giving that darn stuff. Here's the real reason why. The rate of macrolide-resistant strep exceeds 30% in the United States. We've given so many Z-Paks because it's so easy to take that the level of resistant strep with macrolides is huge. It means it's a poor choice for our treatment of strep throat. So they want you to save that for patients who truly are pen allergic. All right? So that's what you should think about and know about with the macrolides. I'm on my last big class, and here it is. It's the quinolones. This morning we talked about the respiratory quinolones, and I told you that ciprofloxacin was not considered to be a respiratory quinolone, and here's why. Ciprofloxacin doesn't kill strep pneumo. Strep pneumo is gram positive. It doesn't kill drug-resistant strep pneumo, but it does a great job of getting rid of gram negatives. It's only a third choice to get rid of an atypical pathogen. What are your first two choices for atypical pathogens? Macrolides, doxy. Your third choice is Cipro. Do you want to be anybody's third choice? Because I don't. All right? So third choice, You got way better choices to treat atypical pathogens. So it's no longer considered to be a respiratory quinolone. When you give Cipro, what you should know is that you're killing gram-negative bugs. All right? Everybody got it? There's only one third-generation quinolone left on the market. Its name is levofloxacin. Amelie calls it the idiot's antibiotic. I call it the idiot's antibiotic because even if you're an idiot and you give levofloxacin to an infected patient, you'll probably get them well. Why? Pretty much if it wiggles, Levaquin kills it. Look at what Levaquin kills. Gram-positives, gram-negatives, the atypicals, drug-resistant strep pneumo, aerobes, anaerobes. If it wiggles, Levaquin kills it. So you might be sitting there having very bad thoughts. These would be very bad thoughts. Amelie, I wish you'd have started with that when I wouldn't have been writing down all that other stuff. When an infected patient comes into my clinic, I'm giving them Levaquin. It works. Those are very bad thoughts, and here's why. Every time a patient gets an antibiotic, every time, even if they take it exactly like you prescribed it, there are always bugs that are born after they take the last antibiotic. You know what those bugs are? Resistant to what they just got. So if it's Levaquin, look at what it is resistant to. That's a very hard bug to kill. You don't want too many of those hanging around the country. So who do we give Levaquin to? We give Levaquin to people who cannot afford treatment failure. Like who's that? A little old lady with left lower lobe pneumonia, and if we don't cure it, she's going to end up tubed and on a vent. Hey, what about your oncology patients who are in the middle of a chemo round and they get septic? What do they get? They get admitted and they get what? Levaquin. Why? Because it's going to knock out those bugs, most bugs. So I want you to look at Levaquin and know it's a great antibiotic. But we don't want to use it too much because the rate of drug-resistant strep is rising, all right, a lot. So we now have almost 2% resistance with Levaquin, and this is a really good antibiotic. It's considered a respiratory quinolone because it kills strep pneumo, which are gram-positives. It kills the atypicals, and it kills drug-resistant strep pneumo. That's why it's a respiratory quinolone. There are 2 more respiratory quinolones. They're 4th-generation quinolones. You know them as Avalox and Factive, and here they are. They kill gram-positives like strep pneumo. They kill atypicals and drug-resistant strep pneumo. So that's why they're respiratory quinolones. But look, they kill and do a good job of killing gram-negatives above the belt, like Haemophilus influenza, H-flu, all right? They don't do a good job of killing gram-negatives below the belt, which is why you would not use a 4th-generation quinolone like Avalox or Factive to treat a urinary tract infection. They don't have indications from FDA for that, and so you don't use them to treat that, and that's exactly why. Everybody with me? Is that a yes? Yes? All right, kind of. All right, so let me tell you something. In medicine, and especially in pharmacology, we like to put drugs in boxes. That's how we know all about them. When we don't know what box to put a drug in, you know what we call it? Miscellaneous. Oh, that's a miscellaneous antibiotic. Well, let me tell you some miscellaneous antibiotics. They really are the only one in their class. They're the only one in the box. That's what nitrofurantoin is, Macrobid, Macrodantin. We use it all the time. It is a great drug. In fact, it has replaced Bactrim 3 years ago as your first choice to treat a urinary tract infection. It has excellent coverage of E. coli, most common urinary tract pathogen. So, hey, wait, Amelie, Macrobid, you tell me that treats MRSA? Mm-hmm. Well, I never saw that used to treat like a MRSA skin infection. I know you never did, and you better not. Let me show you why. It's an important principle when we talk about antibiotics. We never use Macrobid for MRSA skin infections because Macrobid and any antibiotic has to concentrate in the place where it has to kill bugs. So if you had MRSA in your bladder, it would kill MRSA there. But Macrodantin doesn't concentrate in the skin, which means you would never kill MRSA or any skin bug with Macrodantin. So an important principle to remember is that an antibiotic must concentrate in the place where it has to kill bugs. Macrodantin doesn't concentrate in the skin. It concentrates in the bladder. And that's why it's an excellent urinary tract anti-infective. Everybody got that principle? What's another common one you use? You use this one a fair amount. It's the only one in his box, really, and it's Flagyl. Flagyl is metronidazole. It kills anaerobic pathogens. Wait, what is that again? An anaerobe. What does that mean? It's a bug that grows outside the presence of oxygen, like maybe deep in a pus pocket. Flagyl is used in combination with Cipro to treat what problem? Diverticulitis. What's diverticulitis? We'll talk about it in 2 hours. All right. So Flagyl is used to kill anaerobic pathogens, which is why we use it in the gut for something like C. diff. All right. So C. diff is one of those anaerobic pathogens, and Flagyl will kill it. Here's another one that's kind of in its own box. That's clindamycin. You use that one for MRSA. Sometimes dentists use it for deep tooth abscesses. Clindamycin we use for MRSA because it has gram-positive activity, but it does a really good job of knocking out a bunch of anaerobes. So clindamycin we really like. What's the problem with clindamycin? Side effects. Pseudomembranous colitis. Diarrhea. So that's why we don't use clindamycin for strep throat, right? We have an easier antibiotic that gets rid of strep. Zyvox, we use that one mostly for MRSA. Why? Great job of killing gram-positive bugs. What about vancomycin? Vanc. When you give vancomycin to treat C. diff, you give it orally. You don't give IV vancomycin to treat C. diff. Why not? When you take it orally, it concentrates in the gut, and that's where C. diff is. When you give IV vanc, it doesn't concentrate in the gut. You'll never kill C. diff by giving IV vanc. You got it? So the antibiotic has to concentrate in the place where the infection is. So when do we use oral vancomycin? Those little 125 milligram tablets? You use that for C. diff if Flagyl hadn't worked. All right, so there you go with that. Did that help you? Do you see it a little more clearly? You kind of just got to go through it and go through it, but it just needs to be part of your makeup.